The presentation today is part 1 of a 3-part series titled Understanding Cervical Cancer, the Who and the Why. Shown on the screen will be the topics we will touch on and discuss. Should you have any questions, you may type it on the chat box, as we will try to answer it after this presentation. If everybody is ready, let us begin. According to the World Health Organization, cervical cancer is one of the gravest threats to women's lives. Worldwide, approximately 600,000 cases of cervical cancer and about 340,000 deaths from the disease occurring in 2018. Cervical cancer ranks 7th, the most common in both sexes, and ranks the 4th worldwide in women in 2020. Cervical cancer was the 9th most common cause of cancer death in the world. Presented is the age-standardized incidence rates of cervical cancer around the globe. You may note that countries in Northern America, Australia, Western Asia, Southern and Western Europe has very low incidence of cervical cancer, whereas countries in Africa, except for the northern part, countries in Southeastern Asia, Melanesia, Micronesia, and parts of South America in dark color have a higher incidence of cervical cancer. When you plot the countries with high incidence of cervical cancer over those with low, you will find over 85% of cervical cancer cases occur in the low and middle income countries, or the LMIC. Here are the list of regions with high and low incidence of cervical cancer. Countries with high incidence are those above the blue line, whereas those of low incidence below. Among countries with high incidence, you may note that Southeast Asia ranks 7th. In the Philippines, cervical cancer ranks the 2nd most common in women, following breast cancer. Cervical cancer incidence was reported at 7,897 for 2020, while mortality was registered at 4,052. Roughly, we can assume about 11 Filipino women die each day due to cervical cancer in the Philippines. Generally, it is said for every patient diagnosed to have cervical cancer, 1 in every 2 patients, or 50%, will die due to it in the next 5 years. But why cervical cancer be our focus of discussion, you might ask? Why not the most common like breast cancer, or lung cancer, or colorectal cancer? Well, in my nearly 30 years of practice as an oncologist, cervical cancer is not just the only cancer that can be entirely prevented, but it can also be eliminated. Let's watch a video of the World Health Organization's call to end cervical cancer worldwide.
In May 2018, we issued a call to action to eliminate cervical cancer. No woman should suffer from a deadly disease that's both preventable and curable.
The inequity is especially acute in vulnerable communities and in developing countries where the burden is greatest. At the direction of WHO's member states, we mobilized with countries, partners, experts, and advocates to develop a global strategy for elimination, which was adopted by the 73rd World Health Assembly.
To set countries on the path towards elimination, by the year 2030, we must aim to achieve the 90-70-90 targets.
90% of girls to be fully vaccinated with the HPV vaccine by age 15.
70% of women to be screened at least twice with a high-performance test.
90% of women with pre-cancer or cancer to receive the appropriate care and treatment, including palliative care.
We believe that all countries can achieve these ambitious goals.
Please join us in the fight to end the inequity and to restore women's dignity.
Together,
we can eliminate
cervical cancer.
But first, before we discuss cervical cancer, we need first to understand what cancer means. Is cancer and tumor synonymous? Whenever you see a lump or a growth in your body, you call that a tumor. In Tagalog, you call that bukol. Lumps or tumor or bukol that are not caused by cancer are called benign tumor, whereas lumps or growth or tumor that are cancer are called malignant tumors. So therefore, when you say cancer, you are referring to a malignant type of tumor. Here is an illustration showing you the difference between benign and malignant tumors. Benign tumors are well capsulated, meaning they are enclosed in a capsule. And because of that capsule, they are non-invasive and they are slow growing. Malignant tumors, on the other hand, are entirely the opposite of benign tumors. Malignant are not encapsulated, so they spread to the different parts of the body, to the liver, to the lungs, to the brain, to bone, and elsewhere. This is what you call as metastasis. Malignant tumors are fast-growing tumors. We go now to cervical cancer. The word cervix is derived from the Latin root word cervix, which means neck. The cervix is the lowermost part of the uterus that is connected to the vagina. When you place a speculum inside the vagina, as shown, the cervix is the end part that you see. If you were in front of the patient holding the speculum, and this is what you see. So what then is the cause of cervical cancer? The main cause of cervical cancer in majority of cases, somewhere between 91 to 99% of cases, is HPV or the human papilloma virus. Of course, there are other factors associated, no, or make you at risk to develop cervical cancer, like diethylstilbestrol exposure. No, this is a synthetic female hormone that was given to pregnant women between 1940 and 1971 to prevent miscarriage and premature labor. If you are exposed to this, you have a 40-time risk of developing clear cell adenocarcinoma of the lower uterine tract. Another is the prolonged use of oral contraceptive pills. One study found that patients have a 10% increased risk of developing cervical cancer for OCP intake of less than 5 years, whereas there is a 60% increased risk for those with OCP intake with 5 to 9 years of use. Other risk factors that increase your chance of getting cervical cancer include smoking. Women who smoke are said to be twice at risk in getting cervical cancer than those who do not. Sexual history. Becoming sexually active at a young age, especially younger than 18, increases your risk. Having many sexual partners likewise increases your risk. And having one partner who is considered high risk. Another are those with weakened immune system, like in patients with HIV and AIDS and those taking drugs to suppress their immune response, such as those being treated for autoimmune diseases or have undergone transplantation. Another is chlamydial infection. No? Certain studies have shown that chlamydia, which is a bacteria, may help HPV grow and live on the cervix, which thus increases your risk of developing cervical cancer. And lastly, young age at full first term. Women who were younger than 20 years old when they had their first full term are said to be likely to get cervical cancer later in their life than women who waited to get pregnant until they were 25 years old or older. So, if HPV is said to cause cervical cancer in up to 99% of cases. If we can find ways to get rid of HPV, is it fair then to say that we can also get rid or eliminate cervical cancer? So what then is HPV? HPV, or the human papillomavirus, is a group of related viruses which are very common to human. And oh, by the way, we will not be discussing much on HPV here, no, as this shall be discussed in detail in our next webinar, no, part 2, dubbed as Cervical Cancer Prevention, HPV-related cancers, and vaccinations. In layman's term, HPV is simply called warts in English, and in our local dialect, we call it kulugo. Now, HPV is a group of more than 150 types or strain of viruses. Majority of the HPV are harmless, no? However, some HPV can lead to genital warts, whereas some can even lead to the 6 types of HPV related cancers. Shown to you are the 6 types of cancer caused by human papillomavirus. Almost all cervical cancer cases are caused by HPV. 40% of vaginal cancers and vulvar cancer, and over 90% of genital warts in both male and females, 25 to 35% of mouth and throat cancers, 40 to 50% of penile cancers, and about 80 to 90% of anal cancers are all caused by human papillomavirus. The most common route of transmission is intimate skin-to-skin contact. Transmission is not limited to vaginal sex. You can transmit the virus also through oral sex, anal sex, and digital sex. Digital transmission occur when the use of hands, no? When your hands transmit from one infected genitalia to uninfected one. HPV transmission today are not just limited to the union of the male and female. Transmission can occur between men, or what you call as MSM, or men who have sex with men, or the WSW, or women who have sex with women. Some other uncommon sources of HPV infection include infected birth canal during vaginal delivery, or through fomites, no? The transmission of HPV left on objects like sex toys. We go now to symptoms. Shown to you on the screen is the HPV to cervical cancer life cycle. Almost all cervical cancer starts from an HPV infection. That is typically begins during the late adolescent period to the young adult stage. Once HPV infection starts, it can do 2 things. It can be cleared by the body, or it can persist, which later progress to a cervical precancer. The typical time frame between onset of infection to precancer is between 5 to 10 years. Once in the precancer stage, the lesion can either progress to cervical cancer, or it can regress back to be cleared by the body, or it can remain dormant. Shown above is the 5-year survival rate per stage. This means that if you are able to detect the disease during the HPV infection phase down to the precancer stage, the chances of survival are excellent, 100%. However, once the lesion has moved to stage 1 cancer, the 5-year survival rate drops from 85% for stage 1, 60% for stage 2, 30% for stage 3, and less than 10% for stage 4. The problem with cervical cancer is that symptoms do not occur early. They occur late in the disease. Frequently, stage 2 and up. And this is why a lot of women die due to cervical cancer in the Philippines, because they are discovered late. However, Have we discovered them early during the pre-cancer phase, they could have had a 100% survival. And this is where the importance of cervical cancer screening comes in. We can detect women who have pre-cancer lesions at the time of the screening. I know most of you are afraid, but do not forget that if you are diagnosed early, your chance of survival is 100%. And the cost of treatment is even cheap. It's probably less than 10,000. So what is the important message here? The important message is don't wait for the symptoms. Just get screened because cervical cancer screening saves lives. Now, for purpose of discussion, here are the symptoms of cervical cancer. Among these symptoms, the most frequent reason that would drive the patient to seek a doctor is an abnormal vaginal bleeding. No, this is one of the earliest symptoms patients experience, which includes heavy bleeding during menstrual cycle, meaning more blood is coming out, or perhaps longer menstrual period. Instead of the regular 3 days or 5 days, it can extend to a week or 2 weeks. To some people, there is bleeding in between menstrual cycle, meaning there is bleeding per vagina in between your monthly cycle. So every 15 days. Another problem is that some women associate this bleeding with menopause. But a visit to your obstetrician gynecologist is better at this time. Other symptoms can include pain during sexual intercourse, whereas some of the late symptoms include discomfort while urinating or the loss of bladder control. This could only mean that the mass is already probably affecting your urinary bladder. Pelvic pain may reflect on bone involvement as well as leg pain. The rest are non-specific cancer symptoms like unexplained weight loss and constant fatigue. In a study by Domingo et al., this graph showed the distribution of the stage of disease seeking consult at the Philippine General Hospital. Among those 466 new patients reported, 52% of women or majority seeking consult are already at the stage 3, whereas one quarter or about 25% are on stage 2. Mind you that the 5-year survival rate of patients with stage 3 is at 30%, whereas for stage 2 is about 60%. Majority of these women will die of cervical cancer brought about by the lack of awareness that cervical cancer is preventable. Have they attended screening early, they could have been alive today. And this just shows that cervical cancer screening saves lives. We go now to prevention. Let's talk first on vaccination. Shown is the prevention strategy of the World Health Organization. Almost all cervical cancer starts with a simple HPV infection. This infection can come from your partner, a boyfriend or a girlfriend. To prevent this infection, HPV vaccination is recommended to be instituted before the dawn of sexual intercourse. And this is why vaccination is recommended to your children at the age of 9 and 14 years of age. This phase is called the primary prevention, or the phase that prevents you from getting the disease. The second phase of prevention, or the secondary prevention, which is aimed to detect the disease early and prevent it from, getting it worse, is cervical screening. Remember, vaccine do not offer 100% protection, whereas some patients who have not undergone vaccination require cervical screening to detect disease early and save lives. Shown to you are the 14 strains of HPV that can cause cervical cancer. Now, we have three types of vaccine out in the market: the HPV-2, HPV-4, and the HPV-9. Shown to you are three of the HPV vaccines on tabular form. HPV-2 protects you from 2 of the 14 HPV types that causes cervical cancer. It is only given to females up to age 26 and offers 70% protection. HPV-4 is similar to HPV-2. However, they added 2 additional HPV type that causes genital warts, which are type 6 and type 11. Hence, it protects you not only from cervical cancer, but from getting genital warts. Due to this, it can be recommended to boys. HPV-9 is the latest vaccine that has some similarities with HPV-4. 5 subtypes of HPV causing cancer was added to the vaccine, which can now protect women up to 90% from getting cervical cancer. Another thing is that it can be given at any age. Now, vaccine dosing depends upon the age. All patients 9 to 14 years old only require 2 doses, whereas for age 15 and above, 3 doses is required. The frequency of vaccine depends on the brand. Generally, for children aged below 15, the dosing schedule is 0 and 5 to 13 months for the second shot. For those above or equal to 15 years of age, which require 3 doses, the schedule is generally 0, then 2 months after the first shot, then 6 months after the first shot. We now go to cervical cancer screening. When you say screening, it is defined as a strategy to use to look for as yet unrecognized condition or risk markers. In a more convenient way, cervical cancer screening is done to detect potential health disorder or diseases in people like you and me who does not have any symptoms of the disease. The best test in detecting cervical cancer is biopsy, or specifically a cervical punch biopsy. During the procedure, an instrument is inserted basically to punch the cervix to get a specimen, to which is sent to a laboratory for analysis. However, this technique, although it is the gold standard or the best way to ascertain if a patient has cervical cancer, is not recommended to be used as a screening. Just imagine if every time you go to a cervical screening and this procedure is done, where a bit of tissue is removed from you, how would you think your cervix would look like after 30 times or 30 sessions? Plus, the fact that most of the time when you do this procedure, it's without anesthetic. So currently, we have three types of cervical cancer screening methods, namely cytology, which is further subdivided to pap smear and or liquid-based cytology, via or visual inspection with acetic acid, and HPV DNA typing. These screening tests, however, are not comparable to cervical biopsy in terms of accuracy, like sensitivity, specificity, uh, positive predictive value or PPV, or negative predictive value or NPV. No. By the way, we will not be discussing this here. No, we will be discussing that more on our third webinar series. This slide shows a comparative summary of the advantages and disadvantages and performance of all three screening tests. During this webinar, we will just be highlighting to you the superficial differences between the three as we go in detail on our part 3 webinar series. So let us start. Okay, cytology is divided into the conventional pap smear and liquid-based cytology. Both of these tests require the collection of cells in your cervix. Here are some of the differences. In a pap smear, The collected cervical sample are placed on a glass slide. Because the glass slide is a hard surface, in one study it is said that about 80% of those collected are discarded. Whereas, if you place it on a liquid medium, virtually 100% of the sample is collected. Of course, there are other differences, but this is for medical professionals to digest. So overall, the advantage of pap smear is it is widely used in most countries. Because of the extremely laborious process in conventional cytology or pap smear, computer-assisted imaging system is now being integrated into liquid-based cytology. Because of this, there is standardization of the processes, plus more and more countries are now adapting or an increased adoption of liquid-based cytology. Another advantage of LBC mainly is it has a better or a more accurate sensitivity rate compared to the conventional pap smear. On the other hand, the disadvantage of cytology, which is basically both pap smear and LBC, is both are expensive. Expensive in terms of infrastructure that is required. Of course, more infrastructure is required in LBC than pap smear. Both likewise require trained personnel, and both are not suitable in low resource setting, meaning in rural communities or primary or secondary clinics. And both have long assay times, meaning it takes a while before you get your results. Let us now go first with VIA, or visual inspection with acetic acid. Now, VIA, or visual inspection with acetic acid, is a naked eye examination of the uterine cervix. So here, basically, the operator, which is a doctor or a midwife, swabs 5% acetic acid solution to the cervix for 1 minute. After 1 minute, she removes the swab and immediately checks whether there is an acetowhite lesion. So what is an acetowhite lesion? Acetowhite lesions are areas that stain white after placing acetic acid. On this picture, could you see the acetowhite? Presented here is an image of the cervix before and after placement of acetic acid. The image on your left seems to be a normal looking cervix, but upon the placement of 5% acetic acid, you can see the faint white stains called acetowhite lesions. The lesions you can appreciate easily because these pictures were magnified. In the real world, this is the closest you can ever get to visualize directly the cervix without interfering with the external light. So what are acetowhite lesions and what is its significance? The presence of acetowyte lesions reported as VIA positive, which signify the presence of a pre-cancer. On pap smear result, the equivalent are like CIN or cervical intraepithelial neoplasia or pre-cancer stage. Remember, these are pre-cancers, meaning they are not yet cancer. But if no treatment is done, with a few more years, these lesions will turn out to be full-blown cancer. Now, VIA positive is defined as the presence of a sharp, distinct, well-defined, dense, with or without raised margin that are touching the squamo-columnar junction. What the heck is squamo-columnar junction? Well, another definition in VIA positive is that it is the presence of a thick, well-defined acetowyte areas near the transformational zone. What is the transformational zone? Furthermore, VIA negative is reported if the acetowyte lesions are far from the transformational zone or when the faint acetowyte areas are found without a sharp outline border or a streak-like or a line-like acetowhite and a dot pale inside the areas of the endocervix. So what this means is it is not automatic that whenever you see an acetowhite, it is VIA positive. For the presence of an acetowhite lesion to be VIA positive, it has to be near the transformation zone and should be touching the squamocolumnar junction. And this is the disadvantage of VIA. It's subjective. What might be faint acetowhite to one might not be to another one. Here is an image illustrating the squamocolumnar junction or the SCJ and the transformational zone or the TZ. To complicate things, to identify the TZ, you first need to identify the old and the new SCJ or the squamocolumnar junction. The area in between the old and the new is the transformational zone. Now, just imagine trying to identify the squamocolumnar junction and the TZ at this depth. Very difficult, right? Occasionally, you will be encountering visible ulcerative cauliflower growth-like lesions, no, that are bleeding or oozing upon touching. These are reported as suspicious for cancer. For these patients, you may not need to do colposcopy. Rather, you may need to do biopsy directly to confirm cervical cancer. So overall, for visual inspection with acetic acid, its advantage include inexpensive, meaning it requires limited equipment to conduct the procedure, making it ideal for low resource setting. Because its results are immediate within minutes, you can conduct the treatment immediately thereafter. This technique was recommended by the World Health Organization called the Screen and Treat Protocol or the single visit approach. Disadvantages of VIA includes it requires training the personnel, more training actually, and the lack of objectivity or the inter-observer variations or variability, which means one operator may have different report from another operator. The third type of screening is the HPV DNA typing, which is now being recommended by the World Health Organization as the primary screening modality last June 2021. The reason for the shift includes objectivity, as everything now is automated and standardized, and the test has a high sensitivity and good specificity. Furthermore, it is more effective in postmenopausal women. Its major limitation is cost. The test for patients alone cost about 600 pesos already. This is yet without doctors. And imagine the cost of the equipments. At the moment in the Philippines, there seem to be only one center that offers HPV DNA at this point. Another advantage of HPV DNA is self-sampling. Question: what happens next if you have HPV DNA positive or CIN positive in pap smear or visual inspection with acetic acid positive or VIA positive? The recommendation may be for you to undergo colposcopy plus minus biopsy. So what then is colposcopy? Colposcopy is basically your doctor taking a good look at your cervix using a special magnifying instrument called a colposcope to validate the lesion carefully, and that it helps your doctor decide if you need a cervical biopsy or other forms of management plans. If you are not using a magnifying tool, I don't think you can make an actual assessment at this depth on the left, validating if the lesion has raised margin or if the lesion has vessels that can be seen, or even to identify the extent of the lesion. Using a colposcope that is shown on the right, the cervix is magnified and provides you a better assessment of the cervix. And so not to miss anything, The colposcopy findings is documented as shown. Furthermore, a SWEDE score is calculated, and based on the total score, a provisional diagnosis is made, which will determine the final plan and whether you need a biopsy or not. As far as cost of the three screening methods, no, the pap smear, the VIA, the HPV DNA, all these are not yet reimbursable in the Philippines currently. What is reimbursable is the colposcopy part, no, estimated to be around 8,000 pesos plus. We go now to our last topic, no, emerging technology. Recently, I am privileged, no, to collaborate with a South Korean company, AI Dot, no, that is providing a new type of colposcope. The equipment combines the advantages of VIA, or the visual inspection with acetic acid, and that of colposcopy to provide you better accuracy, reported at about 93% sensitivity and 89% specificity, with automated results that you can get in 5 minutes. Their interpretation is done by artificial intelligence, and it immediately provides you a reading as shown, and a report to the patient is sent. Should you refer to be seen by a doctor, the colposcopic images that were acquired can be sent to the doctor remotely for remote consultation and final diagnosis or reading. The doctors too will be guided with the AI result. At this time, we are now referring them to South Korea. But very soon, we are looking for local doctor expert for remote consultation, as the system is now being remodeled to include Philippine territory. This ends my presentation, and thank you for listening.